maybe easier I can speak in English for this talk because it's a bit difficult with this new. I think we talk about a lot of conduction system pacing. The issue here is we are okay, we are stable now with the pacemaker, but how about in patients who need a defibrillator? So I think this is the difficult part. If a patient, you think about the conduction system pacing, but you also need the ICD. Now, currently, the situation is when you're comparing the conventional CRTD, or even with now we talk about the lock CRT, you're using conduction system pacing together with CSD. In fact, in some of the patients, especially who had actually even with left bundle band block, very delayed KRS complex, and then in those patients, the lock CRT is actually better than the LBB area pacing. Okay, so in certain patients, so how we can actually achieve lock CRT with using a conduction system pacing? So the conventional way is actually using a LBB pacing lead, an ICD lead, and also a CSD. So that makes things very complicated. So you can see that this is actually how we are now doing. So we put in a LBB area lead, we put in the defibrillation lead, and also we need to put in the CSD. So that will actually make the system very complicated. How we can actually using a more simplified system to achieve lock CRT? Can we actually put our ICD lead to the left bundle band area for left bundle area pacing? That is actually the question. In fact, there's a many studies have been tried to using existing lead and using different lead to try to do this with conduction system pacing. So this is actually one of the early experience to using a conventional ICD lead and then using a custom-made kind of a sheath. In that time, they're using different, the one we're using for ablation, the R-board, and different sheath. And then we can actually using those sheath to make a specialized curve so that you can actually put your ICD lead into the left bundle band area. So in fact, in the early series, in this acute study, you can see that they can actually using for the LBB area pacing and even try with some of the his bundle pacing with this kind of configuration. Other thing been also been tried. Also, there are a few studies using the Medtronic one. Medtronic actually had this CSC shift, which is 8 French. The ICD leads 7 French. You can actually try to using that, and then you can using that for left bundle band area pacing. Again, this is one of the early experience in this. They were able to successfully implanted CSP in about 75% of patients. Similarly, this is another experience using the same lead system. Now, this is an R-board lead, okay, using the new delivery shift, and then you can see that they again able to achieve CSP in a lot of patients. So now there's potential we can using existing ICD lead and using some of the shift, as long as the size is compatible, you can doing CSP pacing. Obviously, if you look at all the data, so this is summarizing all the data, they are using different shift. Particularly, if you're talking about the lead system, the R-board one actually had a shift that actually can accumulating most of the ICD have been tried. But you see that the successful rate is very variable. So I think you were able to improve the successful rate, it may be actually a better outcome. Obviously, the other thing we will be need to look into, can we using a specific design lead and using the existing CSP shift to deliver it? This is one of the design from the Medtronic lead, which is the only secure defibrillation lead. In fact, this is actually very similar to the existing LBB area pacing lead from Medtronic. So very small size. So if we talk about the existing LBB lead from Medtronic is 4.1 French. A lot of ICD lead is in the range of 8 French, but this only secure lead is only 4.7 French. So very small lead, but they can also doing a defibrillation. In doing the practice, we actually doing whether we can using test the lead's safety and efficacy in a virtual patient, and then also carry a clinical trial to look in the safety and efficacy of this lead in clinical practice. So they've gone through a lot of bench work and able to consistently demonstrating that even with this is very small defibrillation lead, you can able to get a very security 10-year survival-free fracture rate compared to conventional lead. So they're also using different bench tests to look at in X-ray how we can bend and then whether look at the potential fracture and also demonstrate consistently efficacy in this particular lead. So this is the first trial we actually published as a late breaking and also published in Heart Rhythm to look at the outcome for using this lead in a cohort patient. You can see that at least comparing to the usual kind of ICD lead, they're very comparable in terms of efficacy. So in this first trial, we just put the lead as a RV pacing lead or defibrillation lead. So the usual position mainly to test the safety and efficacy of this lead, rather than put into the left bundle band area. So again, if you look at the performance electronically, you can see that the pacing, sensing threshold are very good. And then there's some of this communication rate, like similar to the existing IC lead dislodgement, they are not significantly increased comparing to the conventional ICD lead. And again, some of the reason why we cannot do the successful implant is one of the unique communication with this lead is actually they have a very long coil. They can also have a P-wave oversensing. Compared to ICD lead, who mainly for T-wave oversensing, they also have the issue about P-wave oversensing in the tissue lead. So again, if you look at this is a data to look at the communication rate. If you look at the 6-month and 12-month communication rate, they are very consistent in terms of very small chance of perforation, capture oversensing, and the lead dislodgement is also very acceptable comparing to conventional ICD lead. Again, in the test, the other important parameter is can we successfully defibrillation. So we'll also do a defibrillation test in a subset of patients. Again, it's very clear that almost 98% of patients have successful defibrillation using this lead, using up to 25 joule in this testing. This is a long-term outcome data. So this is follow-up the study now for patient over 24 months. Now we're able to see that again, very consistently in terms of safety and efficacy. Again, what I mentioned, the highest communication rate is actually PO oversensing because of the ICD lead coil is actually inside the part of them in the atrium. And again, if you look at long-term sensing, ATP shock efficacy is very comparable to the existing ICD lead. So in fact, we were able to conclude in this lead, when you put in the usual RV position, able to achieve a successful lead pacing and sensing and defibrillation. So in the next trial now we have been ongoing is, can we actually put that into LBB area? So this is the leader R LBB area clinical trial. So again, we just present a late-breaking trial in this year in HRS. Again, this is a multi-center trial including almost 300 patients. Aim is to look in now, can we put the lead not only in the RV apex, but also into LBB area pacing. So we including 200 patients in the trial and successful implant in 191 patients, and the defibrillation cohort and 162 patients in this particular trial. So in certain proportion of the patient is also from the Asia Pacific region. Successful rate implant is 96%, very high. And in this trial, we are not using a very strict criteria for LBB pacing. So mainly we look at the RBB potential, KRS transition, we see an outply in V1. And again, if you're not able to do this, we're using it fluoroscopically, we're able to achieve a deep septal pacing in this trial. So failure rate to implant is about 8 patients, mainly is not able to achieve the position, not able to fix the lead, or unacceptable low R wave in the trial. And in this trial, again, you look at that, most of them have successfully, we're using either in this case, most of them, larger number will be CRTD, and different kind of strip, existing one have been used in the study. So this is a parameter we're doing in the trial. So we can see that in general, we need to do 2 or 3 times to get the successful position. You can see that the coil was very long. You can see that we need to do the LBB area pacing. You need to kind of make a very big loop into the coil in order to achieve to the LBB area pacing. So again, in the trial, we able demonstrate the successful defibrillation with this lead, even you put into LBB area. And again, you can see that almost 100% people are successfully defibrillation, even you put the lead into the LBB area pacing for defibrillation. So again, we are still ongoing a trial and then look at the outcome efficacy in terms of the performance, in terms of LBB area pacing, and also electoral parameter, and also clinical outcome in some of the patients. So with that, I show you a few cases been done in our center. So this is actually a C5 his shift. So again, you can see that now this is, you can see the calcification. This is a coronary sinus. Now we can put the lead actually now up into the LBB area pacing in this particular case. Again, the other important thing, you need to prolapse the coil into all the RV. Okay, you will see this is the location how we put the lead, and you can see there's a Q band in the lead position in order to achieve the whole ICD lead coil inside the right ventricle. This is the ECG. So you see this is a baseline ECG. This is after the LBB area pacing ECG with this one of the first case we implanted. And again, one of the limitations is you cannot do unipolar pacing with defibrillation lead because this is a defibrillation lead, so you cannot choose. But hopefully in the future, you will be able to do a unipolar pacing. We may actually get a better ECG performance in this kind of thing. Other similar case, we're also using this for the lock CRT. So you see that this is a active CS lead. And then again, we're using the existing CSP shift now to put into the ICD. One of the problem is a lot of time you need to put the lead to the more apical position because in order to achieve the whole coil into the right ventricle, you cannot put to a very higher position. Otherwise, part of the coil will be in the right atrium. So again, in this case, we're able to put in. So you see this is the X-ray to look at the LV lead, the CSP ICD lead. And you can see that when we actually look at all the ECG, so this is a patient with baseline LBB left bundle band block, KRS 165. With the LBB pacing, we correct part of them, 160, but we cannot correct. CS pacing, 145. But if we're doing lock CRT, we actually get the best KRS morphology reduction with this kind of configuration. How about in the future, can we have a designating ICD lead and also a new CSP strip? So this is another study now we are doing with Abbott. This is the new CSP strip from Abbott. So we can see that now we put in the shift. We can also do doing a angiogram to look at the location where we intercept them. And then this is the new active screw lead from Abbott. So we can actually screw the lead all the way. The advantage of that, this is a much usual length of the coil, so you don't need to prolapse the lead a lot. And then you can also go to the conventional CSP pacing location for CSP pacing. So again, you can see that they're much easier to position, and you can go up to a much higher position. And this is a kind of active screw. We can now very similar to the existing Abbott CSP lead. Again, there are other cases we including in the trial. So this is a CRT, lock CRT. Again, you can put the lead into the septal area, and also there's also a CS lead in the coronary sinus. And again, in the other patient, so you see this is a patient with conventional left bundle band block, baseline 168 millisecond, LBB pacing shortened to 155, CS pacing doesn't shorten much, but you can see with these lock CRT, you can see we get the best result in terms of resynchronization in this particular case. So again, this is a very important area. We can now simplifying the ICD lead in those patients to achieve a lock CRT without additional pacing lead in the right ventricle. That will eliminating a potential issue about the long-term tricuspid regurgitation and lead-related problem. So hopefully I can summarizing with you, the LBB area pacing could representing a more physiological alternative in a lot of ICD patients with impaired heart function. And then with the lock CRT, we're integrating LBB area pacing with CSD pacing, may further improving electrical synchronicity and outcome in heart failure patients with conduction system pacing. Currently, we can using the conventional IC lead with a customized shift is feasible, but associating with a lower success rate and high complication. And hopefully in the future, like some of the lead, I show you some of this novel defibrillation lead and the first delivery system should further improve success rate and safety of LVB area IC lead implantation. So with that, thank you for your attention and welcome for any question.